episode, we will be learning about the diagnostic testing and isolation procedures, which includes the importance of symptom recognition, diagnostic testing, quarantine and isolation procedures, as well as the challenges with access to testing, social inequities, and mass gatherings.
You look at the infection rate, obviously is very similar to other jurisdictions in the state and the country, and that is individuals who live in the poverty parts of our county, as well as individuals who are identified as Black. Part of the Black and the Latinx community have been disproportionately affected this entire pandemic. And so when I came on board, I quickly identified areas in Orange County that have higher infection rate compared to the average infection rate in the county, and then quickly worked with a community-based organization to target those what we call hotspots and ensure that we bring resources to the community, to those neighborhoods, as well as bringing access to testing to those neighborhoods. And within a matter of a couple months, we were able to dramatically decrease the percentage of folks who are infected in those areas by 75%. Likewise, since the start of the vaccine program in this country, and so you should know that day one for us in Orange County was December 16, when we vaccinated the first Orange County resident here with the vaccine, and continue to do so. We also quickly identified those community representatives that have been behind in terms of the percentage of the folks who are eligible to get the vaccine and got the vaccine in arms. And in Orange County, again, the number is low in the Latinx as well as the Black community compared to the other ethnic. And so we're moving with the same laser focus in targeting those community and bringing access to the vaccine to those neighborhoods. And so I'll give you an example. Within a week, we were able to increase the number of folks who are interested and want to get vaccinated in the Latinx community from a low 11% to a high 21%. So again, this is not just a healthcare agency work alone. This is truly a public-private collaboration. So we work with local school districts. We work with community-based organizations. We work with the faith-based leader, and also we work with any other community group that have been having access to these neighborhoods, these communities, right? So we work with the Latinx Equity Initiative. We work with the API COVID Task Force to bring access like testing and vaccine to the individual hotspots in Orange County that have a very high infection rate, have a very high case rate, have a very high death rate. Laboratories offer different type of COVID-19 testing. They are referred to as PCR or antigen or serology test. The only test that the county offer and support would be the PCR testing. These are diagnostic tests for COVID-19, and the only test that is reportable to the state. And that's the important piece, is that you have to be able to report to the state so the state can follow what is the infection rate in individual county and then roll that up to the state, right? And of course, the only laboratory that we work with would be a laboratory that have PCR tests that are authorized by the federal government, the FDA, to be exact.
There's the tests that rely on the polymerase chain reaction, or PCR tests. Those are highly sensitive and highly specific. The downside is it takes at least a day to get them back, and sometimes 2 days. There are the antigen tests, which are basically rapid tests looking for bits and pieces of the virus. They usually give results in about 10 to 15 minutes. They're reasonably sensitive and specific, but not absolutely so. So can you have false positives and false negatives? Yes, meaning that is the test is positive, you still might not have the disease. That's a false positive. Or if the test says you're negative, but you really have the disease, that's a false negative. And these antigen tests are more likely to give you these false positives than false negatives, so they're not as reliable. But they're really good for screening large groups. So if you had an outbreak at your school, for instance, and you now needed to go through and test, I don't know how many people are in your school, let's say a couple of hundred at least, maybe 1,000, I don't know. That gets really old really fast if you're doing it one at a time with a PCR test. But with these large or with these rapid antigen tests, you can test the whole school in a day and get results that are reasonably, when you're dealing with a large number of people. Now that false positive, false negative rate doesn't matter so much. And in a very large group, you can get some pretty reliable data and know if this is something that's spreading rapidly through your school and you got to shut it down and send everybody home, or if the cases that you identified that started the process, that's all there is. Everybody else looks pretty good. I think that's reassuring. So the antigen tests are useful for screening, not so useful to tell you specifically, do you have the disease, yes or no? So that's the PCR test, the antigen test, and then there's the antibody test, which is a blood test. So that's a real pain. So you got to go out and draw blood from somebody. And then you run the analysis, and that tells you if you have antibodies to the disease, which means you already got infected.
Even if you test negative, it doesn't mean that you are safe, right? So you still have to continue to wear a mask when you go out of your home, stay physically distant from people who don't live in the same household, and do not gather, okay? A negative test is not a passport for you to stop doing all of that.
As far as how much, it depends on, again, too, what the layout of the housing is and so forth. But, generally, if someone in your household has COVID, as much as possible, you need to try to isolate them in their own room, and if possible, have enough ventilation, if there's a window or a door. And then, like any day in public, you would want to, have a mask, potentially gloves. It depends on how much interaction you have with that person in your household, and understanding not everyone can isolate within their household depending on how it's configured and how many people are in that household.
Obviously, somebody who is quarantined need to make sure that they have all the food supplied to them, they have all the medicine supplied to them. So usually individual have family member will be able to do that for them. For individual who don't have relative, the county arrange for Meal on Wheels and organizations that come to your home and deliver food and delivering medication for you. So if you have COVID, then you will be isolated. So the term is very different. Isolation is 10 days, okay? If you are exposed to someone and then you need to be quarantined. It used to be 14 days, but the federal government has lessened the day to 10 days. Although it depends. I mean, if you are infected by the most recent variant, which are very contagious, then we recommend you quarantine for 14 days. But most everyone is able to stay quarantined for 10 days. And the same reason as somebody who tested positive need to be isolated is that you want to stop the spread, right? And so remember, for people who are exposed, you don't know when you will turn positive. And then the 2 days before you turn positive, you're very contagious. And that's the whole point of quarantine, is to make sure that people don't spread it further.
The challenge and the problems you face in the emergency department can be overwhelming, and a lot of them aren't medical. The solutions for them aren't medical. The solutions are social, and you do the best you can. But when you have these kinds of huge outbreaks, and there isn't an effective strategy to manage them, then basically the entire problem gets dropped on your doorstep. And in the emergency department, you make choices. That's you have imperfect data, because they're not your patients. You haven't followed them for 20 years. You see them for about 10 or 15 minutes, and you have to make a decision about what to do. And it's remarkable. Most of the people who go into this field are pretty adept at doing that. But at some point, there are only so many nurses, so many techs, so many physicians, so many beds to put people in. And you can reach a point where you have to start making decisions about who gets care and who doesn't. And there are ways to do that, but it's tough. And most physicians have never, ever been in that situation where they actually have to choose who lives and who dies. Emergency physicians probably come as close to that, because we do see individuals who we know have terminal disease, and many of them simply don't qualify for anything. They're not sick enough yet to be admitted, but they're usually here as undocumented immigrants, and they don't link to anything, and they oftentimes have to go back to the country they came to try to get health care. So it can be rough, but that's the nature of the job, and they're pretty good at it. So the chance that somebody will sort of misdiagnose you or not appreciate how sick you are is pretty small. The only question will be whether there's enough room at the inn. Do they have enough slots to put you in and enough resources to keep you alive? And we came fairly close to hitting that wall. We didn't get there, but we got close. There is huge disparities, and the pandemic has made these disparities worse. And all you have to do is talk to somebody who doesn't have a lot of resources, and they will tell you that it was tough before the pandemic and it's worse now. It is the nature of the society we live in, and I would love to be able to fix it. Then they're not going to reach out to you, and you're going to get screwed. There's nothing, you're not going to get the vaccine. You're not going to get health care until somebody finds you. Maybe you'll pass out, and someone walking along will see somebody that doesn't look so good and call 911. But it's a really difficult situation, and there are not a lot of obvious band-aids to fix this. There are groups that target these individuals. There are like nonprofits, for instance, like the Salvation Army, the Union Rescue Mission, whose jobs are to try and provide some sort of safety net for these individuals. Emergency departments are the one place in the United States anybody can go, money or no money, and at least get an evaluation. So they'll get looked at, and if they're sick, they'll get admitted whether they have money or not. The problem is, for a lot of people who are not sick enough to be admitted but may need follow-up, they're screwed. Because they get left, the ED discharges them and say, follow up with your primary care provider. And you go, well, I don't have a primary care provider. I live under a bridge. It's like, well, you can try the social services people. The county does have social services. If you have a phone to call them, some people don't. Even when there are these assets that are provided, accessing them, it can be difficult, not because there aren't people that want to help and have resources to help, but taking those resources and connecting them to the people that need them isn't as easy as one would think. And so a lot of people fall through the cracks, even though there are some of these agencies, like the county has certain options that are available. Indigent medical services, there is money to pay for healthcare if you can get indigent medical services. Sometimes it takes a while to get that. You also, of course, have to know that such a thing exists, so you can apply for it in the first place. But these patchworks help, but do they solve the problem?